Okay, good morning. My name is James Danger. I'm an embryologist with more than 50 years experience. And this video for my 38 IVF Dailies YouTube channel is to review 3 articles that were published on 16th of July 2025. So IVF Daily is interested in reviewing recent publications and summarising this both for clients attending IVF clinics and for the staff as well. And they're designed to basically introduce you to key factors affecting IVF and hopefully allow you to understand some of the information being presented during your treatment and really to ask some questions of the doctors at your treatment. So the 3 papers I picked out for review today have all come from the Journal of Assisted Reproduction and Genetics, which I think is an excellent journal. And they talk about the impacts of trophectoderm biopsy on embryos, on the impact of IVF treatment on the outcome of families and parents and children. And the third one looks at the outcome from using mosaic and euploid embryos, which I'll discuss in due course. Okay, so the first article comes from Chinese authors. It's open access so people can read it, and basically looks at the obstetrical and infant outcomes of trophectoderm biopsy on pre-implantation genetic testing after you've the transfer of a single frozen embryo. They asked the question whether doing the biopsy on embryos has any increased obstetric or infant outcomes. They looked at roughly 1,500 patients in the testing group and 600 in the non-testing group. And I have to say, normally, the vast majority of people having genetic testing are for age-related aneuploidy, and consequently, the number of embryos being tested is quite low. And therefore, there is always a chance that some cases there will be no embryos for transfer. And if you look at the clinical pregnancy rate, this is the pregnancy of a positive pregnancy scan per embryo transfer. The authors, like a lot of other people, have reported a higher pregnancy rate. They argue about 52% compared to 45% for the tested group, and a live birth rate per embryo transfer of 44 against 32%. And they also report a miscarriage rate roughly about half, 13% compared to 22%. So it looks pretty good if you're having testing, but I need to make a point here, as I alluded to just before, is that if there are only a few embryos being tested, there is a chance some of those will be mosaic or abnormal. I'll discuss mosaicism in another paper, and the clinic will elect not to transfer those, therefore the transfer will be cancelled. So if you have 100 cases ready for transfer and you test them, you might find up to 25-30% of embryos are abnormal and the transfer is cancelled. So part of the higher pregnancy rate for the tested group is because there are large numbers. There is a large group of cases where there is no embryo transfer at all. However, other studies have suggested if those embryos are put back, some will be abnormal and not implanted or miscarry, but others will be viable. And so the big debate is about whether there is an increased pregnancy rate per cycle started, and most studies suggest that that is not the case. However, what I think is important is the miscarriage rate after genetic testing is almost universally be shown to half what it is if you don't do testing. So even though the rate might be similar, if all the embryos are put back to not being tested, there is still a high miscarriage rate. And that's because about half the miscarriages are due to chromosome abnormality, which is what the testing is for, and half the miscarriages is due for other reasons which the testing cannot elucidate. So one of the real advantages that I think of doing genetic testing is that if you fall pregnant, you are reducing your chance of miscarriage by 50%, and I think that's really important. But the authors went and looked at the early motor development, and they found the infants in the tested group had slightly better milestones at sitting up, crawling, and standing, although the timing of independent walking wasn't different between groups. So there's some suggestion that maybe the children born after embryo testing have slightly more advanced movements, but I'm not sure parents like that. However, there were no differences found between the 2 groups regarding pregnancy complications, infant outcomes, or early motor development. So basically, they're saying that genetic testing of embryos may give you a slightly higher birth rate, but certainly will give you a lower miscarriage rate, and the biopsy itself may not increase any other pregnancy complications or early motor development of the children. And I think that's fairly universal in most other studies. I think the big takeaway from this study, as many others, is that PGT testing may cause fewer people to have a transfer, but if you do have a transfer after testing, your chance of miscarriage is about half. Okay, the second paper I want to look at is one looking at the effects of stress IVF, the stress of having IVF on the parents and children as the family develops. This is also a systematic analysis. Review and analysis coming from Switzerland is also open access, so clients and staff can read this this article, which the address is down here. And I probably would recommend most people considering IVF should read this. But basically, they're just saying that overcoming fertility through IVF treatment is stressful and requires a high level of investment. And the question is, does this stress permeate the effects of the family after the birth? The authors looked at 89 studies comparing some aspects of psychological family functioning between IVF and non-IVF families in the first year. And basically, they showed that the mental health and parental relationship quality was comparable between IVF and non-IVF families. Compared to non-IVF mothers, ART mothers reported slightly lowering parenting stress comparable to better mother-child relationships and higher parental commitment. That is, that ART mothers really appreciate their baby they've got. ART and non-IVF children show comparable intelligence, cognitive and motor development, but they do suggest there's slightly better evidence of better language skills in IVF kids and slightly lower skill performance in ART children, and that I think is something that needs to be looked at in more detail in future studies. The psychosocial development was marginally better in ART children, according to the mother's reports. However, other mental outcomes were comparable, slightly worse. So there is a few little red flags there. But overall, they concluded that family functioning after IVF seems to be similar to that of non-IVF families. ART parents may exhibit protective socio-demographic characteristics, higher resilience and stronger maternal commitment, potentially buffering the stress associated with IVF treatment. So the bottom line is that it's a long time between treatment and birth, and that the stress of IVF has long since paled in significance compared to the stress of being a parent, and most studies would suggest that IVF and non-IVF families are kind of the same. The third part I'd like to quickly review is looking at the difference between mosaic and euploid embryos. Once again, another systematic review analysis from some Brazilian authors. This is not open access, so no one can read the article unless you subscribe. But essentially, from the abstract, you can get some information. Now, I need to tell listeners who the difference between mosaic and euploid embryos is something that they need to get their head around, but it's not particularly complicated. A euploid embryo is an embryo that's made up of between 102 or 300 cells at the time of implantation, where every cell in that embryo is thought to be chromosomally correct. That is, 46 chromosomes, everything's okay. However, mosaic embryos are embryos that started off normal with the right number of chromosomes, but as the embryo continues to divide, some divisions have complications, and those complications carry through with subsequent cell lines. So when they biopsy the embryo, some cells are normal and some cells are abnormal. And quite obviously, depending upon what cells are biopsied and when the errors occurred, there could be just a few cells that are incorrect, and so it's got a very low level of mosaicism. But there could be large numbers of cells, in which case it's a highly mosaic embryo. And so the degree of mosaicism is really quite variable. How long is a piece of string? So there's been a lot of debate about whether you should transfer mosaic embryos or not, and this paper looks at reviewing that data, and they find the following thing, the observations. That the clinical significance of transferring mosaic embryos remains uncertain. Their finding from the review is that mosaic embryos have slightly lower implantation and lower birth rates than euploid embryos, reinforcing the superior reproductive potential of euploid embryos. Basically saying is, if when you have embryos tested, and some are euploid and some are non-euploid, one would prefer to transfer the euploid embryos over the mosaic. However, once implantation occurs, all the other aspects of pregnancy, including biochemical, loss and miscarriage rates, were comparable between the groups, suggesting that implantation is the primary limiting factor of mosaic embryo viability. What that basically means is that if you have an embryo that's mosaic, the degree of mosaicism will influence the chance that embryo implanting, but once the embryo is implanted, it basically pregnancy is no different to any other pregnancy. I need to, at this point, make a comment that it's thought that in many other studies have suggested that the abnormal cells of a mosaic embryos tend to gravitate to the outside of the embryos, which are the ones responsible for the placenta. And therefore, when you biopsy an embryo and looking at the outer layer of cells, you get a increased expectation of mosaicism than otherwise would really occur. So if you have a 10% degree of mosaicism, you might find there's no mosaic embryo and no mosaic cells in the part of the embryo that's going to give rise to the baby, but all the abnormal cells have been pushed to the outside. Therefore, you get an increased expectation of abnormality. And so they go through and make a point that the type and extent of mosaicism will further influence reproductive outcomes, where segmental mosaicism show better prognosis than whole chromosome mosaicism. I don't think clients need to worry too much about that. It becomes a slightly confusing issue. But the important thing they also made was there was a trend towards lower birth weight in mosaic embryos, although the neonatal health outcomes, that is the baby itself, were the same as euploid. But they also make one other point, that there is considerable heterogeneity in the testing of embryos, and that different clinics will use different platforms to estimate whether the embryo is euploid or not. And this has some impact on how they can identify mosaicism. So one clinic might identify an embryo as being more mosaic than another clinic, purely just because the testing. And clients need to be aware that the clinic they're attending, the methodology they're using, may have different sensitivities to identifying mosaicism. We'll hope these 3 reviews have been of value, and I'll leave it there. Thank you.